My name is Dr. Amartej Singh Deol, and we will be discussing a rare peritoneal cerebrospinal fluid pseudocyst formed due to infection in the ventriculoperitoneal shunt. A peritoneal cerebrospinal fluid pseudocyst, otherwise known as a CSFoma, is a rare complication primarily seen after a low-grade infection of a VP shunt. A VP shunt is usually placed due to either obstruction of CSF drainage or decreased absorption. Some causes for this are mild meningocele, hydrocephalus, Arnold-Chiari, and many more. A shunt can be placed to drain the fluid in the peritoneum, atria, or pleura. The patient with increased intracranial pressure due to excess fluid can present with altered mental status, headache, learning disabilities, visual problems, cerebral edema, and eventually herniation. It is crucial to make a diagnosis early in the course. CSFomas present as an abdominal mass, occasionally as distended painful abdomen or altered mental status due to increased intracranial pressure. A diagnosis is made with an abdominal ultrasound or CT scan. CSFomas may resolve spontaneously, though generally require repositioning of the VP shunt and incision and drainage of the pseudocyst. We illustrate a case of CSFoma secondary to a low-grade infection of the VP shunt. A 30-year-old male presented to the emergency department with abdominal pain and swelling and altered mental status. His past medical history was significant for scoliosis, cerebral palsy, meningomyocele, and hydrocephalus. A shunt was placed in the ventriculoperitoneum. Infection was suspected in this patient, and blood, urine, abdominal fluid, and suprapubic catheter cultures were obtained. They were positive for Klebsiella oxytoca and Staphylococcus hemolyticus. Broad-spectrum antibiotics were started. CT imaging revealed a large fluid collection surrounding the distal VP catheter, suspicious for cerebrospinal fluid pseudocyst. Neurosurgery was consulted and recommended surgery externalizing the VP shunt and conversion to a ventriculoatrial shunt, and this was done. Patient improved with surgery and antibiotics with resolution of his altered mental status, abdominal pain, and distension, and follow-up CT revealed appropriate catheter position and the shunt was observed to be draining well. Here in these images from literature, we can see very large abdominal pseudocysts. The possibility of a blocked VP shunt should be kept in mind while treating a patient with a VP shunt who presents with symptoms of abdominal pain and swelling. There should be high suspicion for the rare possibility of a CSFoma. Similarly, in patients prone to systemic infections, as with indwelling catheters like a Foley, clinicians need to stay vigilant for infection of the VP shunt with possible formation of a pseudocyst. Even though CSFoma is a rare complication of a VP shunt, it can occur and cause recurrent blockages. The only definitive treatment is surgical excision of the CSFoma with repositioning of the shunt. Treatment of the infection with antibiotics is required. Thank you.